Risk adjustment clinical documentation specificity. The agenda for today's session is to talk about cancer, active versus being in remission, specifically breast cancer and prostate cancer. We'll also discuss leukemia and lymphoma. We're going to look at the actual diagnosis, the diagnosis specificity needed to assign the ICD-10 code to the highest specificity, and then the clinical documentation required to support that ICD-10 code submitted on your claim. The information shared today is for educational purposes only. We'll be using the 2021 data for accuracy at the time of delivery. This guidance is to be used for easy reference. However, the ICD-10 CM codebook and the official guidelines for coding and reporting are the authoritative references. Specific documentation examples is reflective of the clinical thought process. The information shared today also serves to enhance your implementation of high-quality clinical details for ICD-10 coding accuracy to the highest level of specificity. The goal for today's content is to obtain a high-level understanding of risk adjustment specific to neoplasms. We'll be utilizing the CMS HCC risk adjustment model. Information being shared is in accordance with the ICD-10 coding guidelines, CMS Risk Adjustment Data Validation Guidelines, the American Hospital Association coding clinics, and industry best practice suggestions for risk adjustment success. We hope you learned one thing that you didn't know or that wasn't clear about risk adjustment, clinical documentation, and/or ICD-10 coding, and ultimately, if you take away one tip today to ease your day-to-day documentation burden, it would be a benefit. Best practice for clinical documentation specificity. Specific to risk adjustment data validation audits, recall it's the one standalone progress note. It's not the medical record in its entirety that's used in a risk adjustment data validation audit. It's one data service and your single progress note that must validate those ICD-10 diagnosis codes submitted on your claim for risk adjustment data validation. Does the clinical documentation in your progress note meet the CMS MEET criteria to support the diagnosis codes assigned on your claim for submission? Recall the acronym MEET: Monitor, Evaluate, Address, Treat. Include the diagnosis and what you're doing to monitor, evaluate, address, or treat that diagnosis, and ensure that code is submitted on a claim for submission. So today we'll be talking about cancer. We'll have a high-level review of breast cancer and prostate cancer, active versus remission, as well as leukemia and lymphoma. We'll provide tips for success in risk adjustment data validation. Here's an overview of neoplasms with the CMS HCC risk adjustment model. There's over 1,000 ICD-10 diagnosis codes for neoplasms that are categorized into 5 HCC categories. The 5 HCCs are arranged hierarchically from 8, 9, 10, 11, and 12. Only the highest HCC in each hierarchy impacts the risk score one time per year when completely and accurately documented, coded, and submitted. A disease interaction coefficient is also added for patients who have a qualifying neoplasm and an immune disorder, such as neutropenia or pancytopenia. Here you see on the right, there's about 1,000 plus diagnosis codes that go into 5 HCCs. Only one HCC impacts the risk score. We have HCC 8, which brings the risk score of 2.650, HCC 9, which brings a risk score of 1.018, HCC 10, which brings a risk score of 0.671, HCC 11, which brings a risk score of 0.302, and HCC 12, which brings a risk score of 0.148. Today we'll mainly focus on HCC 12, 10, and 8. Here are the 3 HCCs that we'll focus on today. Neoplasm HCCs in the CMS risk adjustment model. Within each hierarchy, only the highest severity, lowest HCC number impacts the patient's risk score, even if multiple conditions are present. So we have HCC 12, which brings a risk weight of 0.148 that codes out to breast, prostate, and other cancers and tumors, including malignant melanomas, malignant neoplasms of the eye, and benign brain neoplasms. HCC 10, which brings a risk weight of 0.671, codes out to lymphomas and other cancers. It includes malignant neoplasms of the bone, peripheral nerves, and brain. And then you have CMS HCC 8, which brings a risk weight of 2.650 for metastatic cancer and acute leukemia, which also includes all sites of secondary malignant neoplasms. So when documenting for neoplasms, your documentation should always include the status of the condition, the specificity of the condition, and the current treatment plan for the condition. So the status of the condition would be terms such as active or history of. Specificity of the condition would be terms such as benign, malignant, secondary. And then the current treatment plan for the condition would be managed by an oncologist or continue your current treatment. Document and code all neoplasms as appropriate when addressed at the encounter, even if they're currently managed by a specialist. Pulling in documented diagnoses and complications from specialist notes into your current documentation and the patient's active medical problems list is a suggested best practice to ensure conditions are being properly managed. Documentation solely in a problems list, past medical history, or a medications list is not sufficient to show meet for the code submission on a claim. Recall that CMS acronym MEET, Monitor, Evaluate, Address, Treat. An example of good documentation that would pass a risk adjustment data validation audit would be malignant neoplasm of the left female breast, status post-mastectomy on 4/2017, continues Herceptin for preventative reoccurrence, managed by oncology. Specific to neoplasm coding and documentation and the HCC risk adjustment model, most benign neoplasms are not included in the risk adjustment model. Active cancer versus historical cancer, according to the ICD-10 guidelines, indicate that when a primary malignancy has been excised, but further treatment such as additional surgery for the malignancy, radiation therapy, or chemotherapy is directed to that site, the primary malignancy code should be used until the treatment is completed. It's considered active cancer. When a primary malignancy has been previously excised or eradicated from the site and there's no further treatment directed to that site, there's no evidence of any existing primary malignancy, a code from category Z85 for a personal history of malignant neoplasm should be used. Adjuvant therapies to cure or prevent reoccurrence are considered active treatment as long as your clinical documentation supports that. Documentation and coding continued for neoplasms. For complications of a neoplasm, your documentation should include management for the complication of the neoplasm with the treatment only for the complication, sequence the complication first, followed by the code for the neoplasm. Anemia is the exception. Sequence the neoplasm first, followed by anemia in neoplastic disease. For primary versus secondary, document multiple tumors in the same organ should each be specified as separate primary malignancies or secondary malignancies when present. Sequencing the diagnosis code is dependent upon which malignancy is being treated in the encounter, primary or secondary. For documentation of polyps, specifically polyps documented as adenomatous are classified as benign neoplasms. Documentation of hyperplastic alone does not classify to neoplasm. Some common areas found when reviewing documentation for neoplasms: conflicting documentation in the progress note. The cancer is documented as both historical and active in the same encounter. Omitting documented conditions from a claim for submission. Active adjuvant cancer treatment is documented, however, the condition is omitted from the assessment and not coded on the claim for the encounter. Lack of supporting documentation for conditions. The condition is simply listed in the assessment without documentation of M, E, A, or T. The condition is only in a problems list or past medical history list, but it's included on a claim for submission and not supported in the progress note documentation. And then lack of specificity in the documentation. The specific histology of a tumor is not documenting, or lacking laterality, location, stage, and/or status of the malignancy. Some commonalities found in clinical documentation specific to the term history of. Per the ICD-10 guidelines, Personal history codes, which are Z codes, explain a patient's past medical condition that no longer exists. It's resolved and gone, not receiving any current treatment or medications, etc. Current conditions should not be documented as a history of, even when the signs and symptoms are controlled, not currently present, stable, still receiving treatment, medications, etc. Regarding progress note documentation in an outpatient setting, slashes are interpreted as either or. Avoid using slashes when documenting multiple conditions. Diagnoses documented as rule out, suspect, working, possible, all code to signs and symptoms and not a confirmed diagnosis. If the diagnosis is confirmed, use that diagnosis and what you're doing to monitor, evaluate, address, or treat without using terms such as rule out, suspect, working. Avoid abbreviations. If you have a habit of using abbreviations within your progress note documentation, best practice suggests at least spelling out that diagnosis one time and then using the abbreviation throughout the encounter. A common documentation and coding error example. The situation is the progress note documentation indicates a history of breast cancer, status post-mastectomy, completed adjuvant therapy without reoccurrence of disease, coded as active cancer in the assessment and on the claim. The recommendation is to code as a personal history of malignant neoplasm of the breast. Z85.3 would be appropriate in that situation. Per the ICD-10 guidelines, when a primary malignancy has been excised, but further treatment such as additional surgery for the malignancy, radiation therapy, or chemotherapy is directed to that site, the primary malignancy code should be used until the treatment is completed. In that example, it would be active cancer. But when the primary malignancy has been previously excised or eradicated from its site, and there's no further treatment directed to that site, and there's no evidence of any existing primary malignancy, a code from category Z85, personal history of malignant neoplasm, should be used to indicate the former site of the malignancy. Specific to adjuvant therapies to cure or prevent reoccurrence that are considered active treatment must be supported in your clinical documentation and stated as such. Documentation of current neoplasm versus a history of. Current, still exists in the body. Active treatment, even aftercare. Determining the effectiveness of surgery within a global post-op period, you'll code the neoplasm as active. When the patient is receiving active treatment for the purpose of cure or palliation, and or when the record clearly shows A, unresponsive to treatment, B, the treatment plan is watchful waiting or observation only, or C, the patient refused further treatment, it will still be coded as an active neoplasm. Adjuvant therapies for cure or palliation is any treatment given after the primary therapy to increase the chance of long-term disease-free survival. Things such as chemotherapy, radiation therapy, hormone therapy, targeted therapy, or biological therapy used as adjuvant therapy to cure or palliation should be documented within your progress note documentation and stated as such. The neoplasm will be coded as a true history of when the primary malignancy has been excised or eradicated, when there's no further treatment directed to that site, when there's no evidence of current cancer, when the patient's not currently under any treatment, and even when the patient has a follow-up exam specifically monitoring for reoccurrence, it would still be coded as a personal history of Z code. Specific to clinical documentation for breast cancer and what we need to know in your clinical documentation details. We need to know the breast cancer site or sites. Is it primary or secondary? We need to know the treatment plan. Be sure to document a clear and concise plan. Is it active versus surveillance? The documentation should represent that. When adjuvant therapy is being used, your documentation needs to clearly state the purpose of that therapy. Is it curative, palliative, preventative, prophylactic? Do not document a simple statement of quote-unquote breast cancer to describe history of breast cancer. And a history of breast cancer includes medical surveillance following completed treatment. Some clinical documentation specifics for breast cancer would be to include the breast cancer sites, primary and/or secondary. Document whether the current breast cancer is primary, secondary, or in situ, the laterality, left or right, the specific site, the areola, the nipple, the outer quadrant, the central portion, etc., and any specific secondary sites. Documentation should also include a treatment plan. Document a clear, concise plan of care. Clearly indicate active treatment of current breast cancer versus surveillance of historical breast cancer to monitor reoccurrence. When adjuvant therapy is used, your documentation should clearly state the purpose and goal of that adjuvant therapy. Is it curative, palliative, or preventative? Some additional details regarding adjuvant therapy for breast cancer, which is treatment given after the primary treatment is completed. Adjuvant therapy can be used to destroy remaining cancer cells that are undetectable and/or lower the risk that the cancer will come back. It may include things like chemotherapy, radiation therapy, hormone therapy, targeted therapy, or biological therapies. Some drugs used for adjuvant therapy would be tamoxifen, Arimidex, Femara, and so on. Ensure that your documentation includes details regarding the adjuvant therapy. Document the purpose of the adjuvant treatment of the breast cancer in each case. Is it curative, being given to cure breast cancer? Is it palliative, given to relieve the symptoms and reduce suffering caused by breast cancer without affecting a cure? Is it prophylactic or preventative, given to keep the breast cancer from reoccurring in a person who has already been treated? Code breast cancer as current, specifically when the progress note clearly shows documentation of active breast cancer receiving current active treatment, which in some cases could be adjuvant therapy. When the documentation clearly shows that the breast cancer is still present but unresponsive to treatment, or the current treatment plan is for observation only, watchful and waiting, or the patient has refused further treatment, the diagnosis will be coded as current. Regarding breast cancer, remember that your documentation should include the breast cancer site, primary and secondary, as well as a treatment plan for the cancer. Do not document a simple statement of breast cancer. Be sure to provide specificity such as primary, secondary, in situ, the laterality, the specific location, and any specified secondary sites. Avoid vague documentation. For an example, breast cancer stable. Best practice documentation should include active breast cancer, left outer quadrant, undergoing chemotherapy, scheduled to see oncologist next week. Use the active medical problems list to your advantage. Choose the full details of the breast cancer in the electronic health record descriptor, primary breast cancer of the left breast outer quadrant, and use those details to drive your clinical documentation. If there's metastatic cancer, specify primary and secondary site for coding accuracy. If documented and coded accurately, metastatic cancer falls into a different HCC category. Some information regarding prostate cancer. Generally, a PSA level of 4.0 or less is considered normal in most cases. Some men with a PSA level below 4 do have prostate cancer, while other men with a PSA above 4 do not have prostate cancer. A continuous rise in PSA over time may be a sign of prostate cancer. Regarding prostate cancer treatment options, you have watchful waiting and active surveillance, surgical removal of the prostate, cytosurgery, chemotherapy, hormonal therapy, external radiation, and internal radiation radioactive seed implantation. In cases where the documentation is vague or unclear, the coder should query the provider for clarification. Documentation and coding for prostate cancer presents a special challenge. In most cases of prostate cancer, it's slow growing and can be observed and monitored for many years with no active treatment. Your documentation should not be vague because it can lead to erroneous coding. A final impression of prostate cancer, check PSA, is vague and ambiguous. It does not clearly indicate current active cancer over historical cancer. Do not document a simple statement of prostate cancer for which there is no active treatment and/or no evidence of disease or reoccurrence. Best practice for documentation of prostate cancer example: active prostate cancer, radio seed implant post 2 months, continue to check PSA. Use the medical problems list to your advantage. Choose the full details of the prostate cancer in the electronic health record descriptor. For example, primary prostate cancer, primary prostatic adenocarcinoma. If there is metastatic cancer, specify the primary and secondary sites for accurate coding and risk score accuracy. Here's another quick review of active versus historical cancer. Most benign neoplasms are not included in the risk adjustment model. Specific to the ICD-10 guidelines, active cancer versus historical cancer. Active cancer is when a primary malignancy has been excised, but further treatment is directed to that site. You'll want to code as active code. When primary malignancy has been previously excised or eradicated and there's no further treatment, then it'll code out to a personal history of cancer. Here we're going to review a few tips regarding leukemia and lymphomas. Leukemia and lymphoma. The ICD-10 coding guidelines for leukemia and lymphoma are the only exclusion to the rule. Unless stated as cured, even when stated as a history of, the code remains active. Specific to lymphoma, they're divided into 2 major groups: Hodgkin lymphoma and non-Hodgkin lymphoma. Hodgkin's lymphoma is cancer of the blood and bone marrow that affects the lymphatic system. Non-Hodgkin lymphoma affects the lymphatic system, in some cases involves bone marrow and blood. Lymphomas are classified into ICD-10 diagnosis categories C81 through C88 and require more specificity in your documentation. Your documentation should show the type of lymphoma. Is it Hodgkin, non-Hodgkin, follicular, non-follicular, mantle cell, etc.? What's the histology? Is it nodular, sclerosis, mixed, lymphocyte-rich, etc.? The location, whether it's in the lymph nodes or organ, and then the status of the disease, active treatment, in remission, or no clinical evidence. Lymphoma patients in remission are still considered to have lymphoma unless it's stated as cured, so you'll always assign the appropriate diagnosis from the C8X category. Active lymphoma. In an effort to code active lymphoma and not a history of, look for the following. Is there active treatment? Is the patient currently receiving active treatment such as watchful waiting, chemotherapy, radiation therapy, a stem cell transplant, etc.? You'll want to code this as active lymphoma. The patient choice. A patient who is diagnosed with cancer and has been counseled in regards to his or her diagnosis may choose not to have any treatment. This is still coded as active cancer. A patient who is newly diagnosed may not have a plan developed yet for treatment. This is also coded as active cancer. And specifically, lymphoma patients in remission. Patients who are in remission are still considered to have lymphoma and should be assigned the appropriate code from category C81 to C88, not a Z code. Coding of leukemia, cancer of the blood and bone marrow. Document the specific type of leukemia. Is it chronic lymphocytic leukemia, which is the most common form? Is it acute lymphoblastic, chronic lymphocytic of B cell type, hairy cell, or adult T cell? Be sure to include the specific type of leukemia in your documentation, as well as the documentation of the status. Is it acute versus chronic, not having achieved remission, in remission, or in relapse? Be sure to include the status of the leukemia. Here's a quick view of the CMS HCC crosswalk for HCC10, lymphoma, leukemia, and stem cell transplants. You see the ICD-10 code on the left, you see the ICD-10 narrative in the middle, and you see the HCC on the right. Specifically wanting to call out to leukemia, unspecified, in remission, coding to an active code. Be sure to document and code stem cell transplants for patients that receive this treatment. It's an additive risk weight. For example, Z9484 stem cell transplant status goes to HCC category 186 with a risk weight of 0.823. And then leukemia in remission codes out to C9591 HCC 10, which brings an additional risk weight of 0.671. Specifically to CMS HCC risk adjustment, clinical documentation, and coding impact. Ensuring that all diagnoses are documented at the highest level of specificity in your progress note and appropriately assigned and submitted on your claim is detrimental to risk adjustment success. Report all chronic HCC conditions a minimum of 1 time per year, but best practice suggests 2 times or more. Accuracy of disease burden and risk score is dependent upon the detailed clinical documentation specificity in your progress note for ICD-10 diagnosis code assignment and claim submission. Use the active medical problems list for accuracy. Add all chronic conditions and the status conditions to the patient's active medical problems list to the highest level of specificity in the narrative, and use the assigned narrative to your advantage to drive the details in your clinical documentation. A brief high-level recap. Incorporate diagnoses from specialist notes into your patient's active medical problems list to the highest level of known specificity and use the descriptive narrative to your advantage. Use the active medical problems list to your advantage by using the descriptive narrative to drive the details in your clinical documentation in the progress note. Specific to neoplasms, attention to the term quote-unquote remission, which is commonly known as resolved and gone. For leukemia and lymphoma, use an active diagnosis code unless stated as cured and no longer existing. Only if stated as cured, assign a Z code for personal history. Otherwise, assign the appropriate code for an active condition even when stated in remission. Specific to cancer and neoplasms, such as breast cancer and prostate cancer. Unless documentation shows the status and treatment plan for active cancer, assign a Z code meaning resolved and gone, no longer exists in the body. Assign a personal history of code or seek clarification from the provider. This concludes the presentation for today. We want to say thank you for your time and we really appreciate you. The small changes made in your clinical documentation today can make lasting effects in the future.